Management Agency, the Hawaii Healthcare Association of Hawaii, Hawaii Association of Directors of Nursing, Hawaii Medical Directors Association, and Mountain Pacific Quality Health. Next slide. Based on participation during the last 2 weeks, our presentations will now be 20 to 30 minutes in length, and we will leave more time for questions and discussion up to about 3 p.m. because we have so many people engaged, and it's hard to cut people off. So please use the chat box to submit any questions that you may have. Okay, next slide. I just wanted to show you our upcoming sessions and highlight them for you. Today we're talking about staffing strategies, and next week we're going to be getting through your first case, and then we're going to have a discussion on COVID conversations, and then the following one on COVID units and cohorting. So a lot of exciting topics coming up, so please make sure you invite all your colleagues and friends.
Hey, Ida, I think that the days and the dates are off.
Yes, I see the Monday, Wednesday thingy is off, so we're going to have to correct that. But that's the dates are correct. It's the day of the week that's wrong. So we'll correct that. Okay. As of today, good news. Next slide, slide number 4, John. As of today, we will be offering CMEs. We were able to squeeze that in at the last minute, so nurses can use these for CE purposes as well. We can also offer certificates of attendance to all participants who complete an evaluation, and if you haven't registered, we encourage you to do so after this webinar. And then the evaluations can be found on our website under the evaluations tab or by following the link in the chat box. So we ask you at this time, in order for attendance, if you have called in by phone, and you can, if you are on the webinar, type in your name in the chat box for attendance purposes. And for those of you calling in on phone, unmute yourself and tell us your name and we can write it down. I'll give you a minute to do that in a sec. And then the final announcement for today is that this is a follow-up from our session on April the 20th on getting ready for telehealth. The folks from the Pacific Basin Telehealth Resource Center wants to provide assistance to all of the facilities to help you provide telehealth services. So please feel free to join them, and that is the Zoom ID and the link, and the date set is for April the 30th from 1 to 2 p.m. And we'll put that information in the chat box as well. Okay, so we just want to open up at this time. I'll welcome everybody, and if you are on telephone, please unmute yourself and just give us your name, and I think Michaela and John will be collecting your names. Thanks. I don't hear anybody unmuting themselves. We have a lot of shy people on the phone.
Oh, Naomi Marita.
Okay. Anybody else? Just a couple more. Okay, well, maybe afterwards. So today's topic is staffing strategies, and our speaker is we're inviting back Kathy Owens. She's a nurse and the Chief Clinical Officer from Avalon, based in Avalon Healthcare.
Salt Lake City.
Salt Lake City, yeah.
It's okay.
And, anyway, she helped the Avalon facilities through the COVID surge in Seattle, Washington, and she comes with a lot of experience, and so I'm just going to hand it over to her and let her take it away.
Thank you so much, and thank you all so much for this opportunity. It's great to be back with you, and I'm so impressed. We have a great showing on a Friday afternoon, so that's very exciting. Next slide, please. So the whole purpose of today is to talk about staffing strategies. When we've worked with facilities that are undergoing either anticipating they could get a COVID positive case or they get a COVID positive case, one of the biggest concerns that is expressed is, what do we do about staffing? Because we do exist in a world where staffing is at a premium, even before the COVID-19 pandemic. And the pandemic has actually heightened our awareness of that. So today what we're going to do is give you some thoughts that can help you be prepared for staffing shortages that might accompany a COVID situation in your facility. Next slide, please. So the best way to be prepared is to have a battle plan, right? And this is such a battle. Many of us have referred to, I always say it's the real war has always been with the microbes, and it feels like we're living that now. This is a war of sorts, but with a very invisible enemy, which makes it a little more difficult. But the good news is we do have strategies that you can embrace to help you be as prepared as possible for what could potentially come down the pike. And that helps reduce everybody's anxiety and just sort of calms down. And the most effective leadership is leadership that remains calm during a crisis. So we're hoping to give you those strategies, or some of those strategies today. Next slide, please. So think about, what does a battle plan require? I love this analogy of thinking about this as a battle plan. Well, the first thing is everybody thinks about is sufficient ammunition. So we have to make sure that we've got that ammunition. And one of the first steps is to think about, what are we really dealing with in our facilities? And now that we will be getting expanded testing capabilities across the country, we're going to be able to get a better picture of what we're dealing with. Up until now, it's been a bit of a challenge, and it really depends on what tests have been available at the local level. The second is make sure that we are in sufficient armor. And our PPE is our armor. It is the cornerstone of how we protect our staff and how we protect our residents. So really thinking about PPE being that armor. And then having maneuvers, or really rehearsing what it is we need to be doing in the different phases of this battle that we're in. So well-rehearsed skills of use of PPE, which we've talked about before, really equals stellar infection control. As I mentioned, it's the cornerstone. So we really need to make sure that we've got our PPE down and organized. And then having the incident command structure, which is part and parcel also of what we do for our emergency response and disaster preparedness. We have organized and coordinated activities. And hopefully you can walk away today with some sense of what that can look like as it relates to staffing. And of course, nothing can be accomplished without a great team, or very little can be accomplished without a great team. So really creating a dedicated team. And the more you're prepared as a leader, the calmer you are, the more your team will stand behind you and coalesce and shine in this moment, not just get the job done, but shine. But we must be supporting their morale as the leadership as well. And we'll talk a little bit about that. Next slide, please. So to be prepared, we have to have training, education, education, education. So all staff should get COVID and PPE training. And my sense is everyone's been doing that. That's been a big part of how we have been arming ourselves and preparing ourselves for the past almost 8 weeks. It's hard to believe this has been really before us for almost 8 weeks. Also want to reference you to the University of Hawaii, Manoa School of Nursing online COVID modules as a great resource. Something else you may want to think about that is very important, and we talked about this our last session, is to have a PPE buddy system. So we are watching each other to make sure our technique is the best, that we are following all the steps and we are maintaining what's contaminated away from what's clean. So we are keeping our techniques stellar so that we can protect our staff and our residents. And this buddy system is the best way to do that. It helps us to stay on our toes. And you can Also get nursing assistants at local CNA schools to assist you. Then just as a reminder, there are CNA waivers that are available. Next slide, please. A big component of a good plan about staffing shortages or your emergency staffing plan is to think ahead. And thinking ahead means, what do you do with what you already have? So you want to take clear stock of what you have. What is your current staffing model? What is your current staffing capability? How many open positions do you have? How many positions do you think you might need should there be a COVID emergency? An important step in looking at what you currently have is looking at your current staff and what are their skill sets? And how could they step out of their current role, step onto the floor, and help with resident and patient care? This is some examples. Medical records. You could have them answer call lights, help pass water, get personal items. Frequently, our medical records, HIMs, have a healthcare background and maybe a CNA already, a CMA, or a nurse. So know what your capabilities, again, of your current staff are. Therapy staff can be so helpful. They can provide that personal care, and they provide it, and they can help teach and assess residents all at the same time. It's awesome to be able to have our therapy staff help us with day-to-day care. I love it on a good day when our occupational therapists are in with our residents, helping them groom prior to going down for breakfast, for example. It's a bonus if we are able to have therapists help us out on the floor. Of course, administrators, DONs, managers, they have leadership roles, but we may need to have them assume different types of roles during a staffing shortage or emergency. As you know, the DONs are all nurses, but other managers may have other skill sets. Administrators have other skill sets. Frequently, administrators have performed a specific role in a facility prior to becoming an administrator. So just think about how could we parlay that into an improved staffing approach if we run into a shortage. Of course, nurses can help with assisting to dine. Nursing assistants can also help with activities, can help with the executing the behavioral management care plan for the residents. And social services, of course, can help with activities and behavior management. Excuse my puppies. Next slide, please. Another strategy that's really important, and you can start again with this now, is looking at the medication pass. And I think Dr. Wen has spoken to this as well in a past session. But optimizing that medication management, deprescribing if it makes sense and if it's clinically appropriate for the resident. Some of the other thoughts that some of the other steps you can take, and you should take this in conjunction with the resident, resident's representative, the pharmacist, the attending physician, the nurse practitioner or PA, the whole team that works around pharmacy services can be a part of this discussion. But think about what meds should we stop, should we reduce, or should we change? And those can include medications like vitamins, supplements, the frequency of meds, the use of long-acting agents may be helpful. Remember, one of the key interventions for reducing the transmission of this virus is to also manage the number of interactions with the resident or patient. If we want to be able to interact with our residents and patients. We want to be able to observe them and assess them. But we also want to bundle care and try to reduce the number of contacts as long as it's clinically safe and appropriate. So one of the first ways is to look at that medication regimen. Then look at how the meds are given. You may want to think about changing crushed meds to liquid or transdermal, insulin to orals, to reduce some of that time frame that is needed to be in the resident's room. You want to look at how many meds are being monitored. For example, how many of your residents in your facility are getting a daily set of, well, we're getting a daily set of vital signs for everyone now, but are they getting additional vital signs for the medications, say blood pressure for antihypertensives? Can we reduce the frequency of some of that monitoring? So think about that. We might be able to reduce some of the frequency of the monitoring for our long-term care residents. And this actually can apply for even post-COVID days. It's really important that we are clinically appropriate and targeted with our interventions, including how we monitor. However, in this world, I know that we are monitoring everyone's vital signs, temperature, and frequently pulse oximeter, as well as symptom assessment or monitoring on at least a daily basis. And then if you're in this situation with a COVID suspected or COVID positive, you know, in our company, we are asking that we increase the monitoring of the vital signs and of the symptoms to much more frequently if we have COVID suspected or a person under investigation. And definitely we go into a more frequent monitoring when we have COVID positive. Looking at when the meds are given, trying to consolidate. If something is not really necessary daily, then would it make sense to change it to PRN? And then review your meds for specific symptom management, especially with COVID. And this has been quite popular, and you've probably heard this already, but looking at what aerosolizing procedures do the residents require? And can you get those changed? Because when you, with the COVID virus, with coronavirus or COVID-19, when you use nebulization, when you use a forced air approach, that actually aerosolizes the virus. And the virus becomes much more contagious and dangerous at that point. So the first step many of us have taken is to transition away from the small volume nebulizer, the SVNs, and to start using multi-dose inhalers. The other pieces that you can do around this is if the resident is able to apply their own CPAP or BiPAP, then you want to encourage them to do that. But before doing that, you should do a self-administration of medication assessment to make sure they're safe in doing that. Then you can, you also need to stay aware with your multi-dose inhalers about where they get stored. And this is something that is like in the evolution that occurred to us recently that we need to be doing, because it's so easy to take that MDI and put it back in the cart. Now it's intermingled with other people's MDIs potentially and could be causing some cross-contamination. So we're recommending that there be a self-administration of medication assessment for those who you think are safe to keep their MDIs in their rooms, but you should have a place where that's locked up as well in the room, and have a lockbox in the room, or lock the top drawer of the bedside table. That is something you'll have to determine on your own, depending on what's happening with your facility. Next slide, please. So now let's talk a little bit about, we talked about getting prepared with education and PPE and training and knowing the disease processes we understand at this point about COVID. And we've talked about how to reduce some of that interactions by managing medication regimens. Let's talk now about the COVID unit dedicated staff. And it is also the time to start talking about it now before you need to implement dedicated staff on your COVID unit. These are just some suggestions of models that you may want to consider for your COVID unit. typically it's been our experience, and we've only had limited experience, but also learning from others, that this is one of those situations that may start out slower and then mushroom as you get more testing. So you may start a COVID unit out small, and you may have just 1 or 2 residents in that COVID unit. So it really makes sense to go to a primary care nursing model in that case. So having a nurse for, say, 1 to up to 4 residents is a reasonable model. And you want it to be completely self-contained, and have a process for bringing in supplies, medications, food, linens, etc. You want to have a transition plan on how someone brings those items to the COVID unit, and the COVID unit staff then take those items. So you really have to think through, what is your process to get items in and out? What is going to be your process for caring for the residents? You do need to assess these residents' needs. If a resident is a 1-person assist, then it may make sense also to have a primary nurse only model. But if you have residents who require more than 1-person assist, or more extensive assist, or 2-person assist, then it also then makes sense to think of more a team model, and you bring a CNA into the mix so that together the nurse and the CNA can provide care to this resident. We found it to be helpful to give, as an example, like 3 12-hour shifts on, 3 12-hour shifts off, and to rotate that. That provides a nice balance of working pretty intensively and then being able to be at home. Because remember, these individuals are working a COVID unit. They will have some concerns about taking that disease process home, and they don't want to transmit it to their family members. So you may consider even offering lodging to these individuals, so they have a block of time in the COVID unit, 12-hour shifts, but they still maybe stay in a hotel. And then when they can go home, it's for a block of time, and it's just easier to manage. That's just one suggestion. You're going to have to think through what works best for your staff in your facility. We are also using walkie-talkies. We actually install zip walls. We have antechambers so that people can change in and out of their PPE and get into the COVID unit. In some cases, we've been able to dedicate a resident room, and that allows the staff member to actually shower before they leave. In some cases, I'm hearing that there's the staff member comes in, changes out of street clothes, and then showers, changes back into street clothes when they leave. And I think we talked about some of that last week. And even offering to do their laundry, even offering them scrubs if they would like for you to provide that for them. And of course, it's much more attractive to work this type of unit if there is a pay premium. So I will tell you that pay premium is quite varied. I belong to an email group with my counterparts across the country, and people are paying quite the range on this premium per hour. But you may want to start testing to see what would that premium need to look like so that you're prepared to put that in place if you need to establish a COVID unit. Next slide, please. So this is, these are some of the things that we do run into, and this is where people, I can see fear in their eyes when there's a discussion that you've got suspected residents, or you may have some COVID positive residents, and the health department says it's time to do a test for all residents and all employees. And everyone takes a deep breath and sometimes a big gulp and says, oh my goodness, what are we going to do if people come back positive? And so I think it's really important to be prepared for that question as well. And that's why you go through this process of all of the preparation. A successful project is based on 90% planning. And so it's never too early to start having these conversations. But there are some tips to keep in mind as you go through this. First of all, I'm going to walk through this slide, and then we're going to talk about where we are with the CDC in terms of contingency and crisis strategies, which, just like with PPE, it gives you a little more permission to be able to manage within some guidelines. But let's first look at, if staff do test positive, when can they return to work? And the conventional approach is this: staff at high risk of exposure must quarantine for 14 days. So I want you to stop for a second and think, what constitutes high risk? And remember, when we were talking, a lot of this is about the PPE. And was that healthcare personnel, were they wearing PPE at the time of the exposure with a resident, for example? Were they, and this is more in an exposure capacity, so was the resident wearing PPE? And what kind of procedure was occurring, and how long and how close in contact was this healthcare personnel with the resident? Those are all the factors that get factored in to if someone is a high risk or a low risk of exposure. So if it's just an exposure, not really a positive test, but if there's high risk exposure, we do recommend quarantining for 14 days. If you're low risk exposure without symptoms, you may actually be able to keep working, but checking your symptoms every 12 hours and using stellar PPE. So think about the high risk of exposure in the quarantine for 14 days. That would be if you are in close contact under 6 feet for more than 10 minutes of exposure without PPE. So most cases in most of our facilities, most of our personnel are already in PPE. There at least should be in a mask, and we've actually instituted face shields and/or goggles. And when we say mask, remember, we're talking about a surgical mask for our healthcare personnel, not necessarily a cloth mask. If it's a cloth mask alone, then that does raise their risk. If it's a cloth mask with a face shield, that begins to lower their risk. But depending on the contact, you may determine they might have been at a medium or a higher risk. So it's all about that risk exposure. And there is guidance from the CDC that talks about the risk of exposure and how to walk through that. Now, if you want to bring people back to work, you can do a test-based strategy or a symptom-based strategy. And we are advised to use the test-based strategy if it's available. The test-based strategy is based on that there is signs of a clinical recovery, which would be signs of no longer having a fever without the use of antipyretics, and the symptoms have improved or have subsided, and then associated that with 2 negative PCR tests, that's the nasal swab test, at least 24 hours apart. So having those 2 negative PCR tests and the symptoms, the fever being gone without antipyretics, and the respiratory are the symptoms of COVID being subsided or improved. That is considered a test-based strategy. We really want the symptoms gone. I will say that we understand that the PCR test has anywhere between a 25 to 35% false negative outcome. That's also why you want to do 2 in a row. And that false negative could be based on technique. So you want to educate your staff on how to get a good nasal swab if your staff is doing the testing. But also it could just be they did not pick up any viral RNA fragments, or any viral RNA, sorry. But that is the advised strategy. Many places are still using the symptom or non-test based strategy, which would be if you are COVID positive and you have symptoms, you would quarantine for 14 days and at least 3 days after recovery from symptoms. Actually, CDC has just reduced that to a 7-day time frame. But our practice as an organization, if we can afford it, from a staffing perspective, we are still trying to keep people off for a total of 14 days. If you're COVID positive staff and you're asymptomatic, it is recommended in the best conditions that you stay home for 14 days. You can actually return sooner, but you need to demonstrate that you have a staffing situation and it would support returning sooner. Next slide, please. So I want to take just a moment though and talk about the concept of contingency and crisis staffing. So on contingency staffing is when you know that you are already struggling to recruit people to work in the facility because of the global challenges with staffing. And you have a sense that the staff are fearful and they don't want to work in a setting, even if we have relaxed guidelines. In a contingency staffing mode, you just need to document in your QAPI process that you determine that you are in contingency mode, that you have reached out to agencies you're not able to get staffing, you have been in communication with your coalitions in your community to see if there is any additional assistance or people are aware of any additional staffing. So you just want to document you did those steps before you claim contingency staffing. And then crisis staffing is when you have not been able to get any additional assistance and you've really exhausted everything and you've gotten to the point of reaching out to say FEMA and the National Guard to be able to assist you. That's more of a crisis mode, and you want to document that in your QAPI process as well. In case it's ever come into question, why did you do what you did? You want to show your rationale in a paper trail. So what the contingency and the crisis mode allow you to do is it allows you to consider, can I bring people back sooner? So if you're in a crisis mode, you can actually bring a COVID positive asymptomatic employee back and have them work on your COVID unit. But you don't want to do that until you've reviewed your plan with your health department, because they understand the risk of exposure and how to mitigate the potential ongoing risk in the facility by bringing a COVID positive employee back to work. But you can do it if you follow a process. And I think for me, that's reassuring. In reality, if we have good, solid PPE and PPE technique, it does offer extensive protection to the resident if they're working with a COVID positive staff member, if the staff member is following PPE technique. So it is, CDC has relaxed some of the guidance so that it helps us be able to bring people in to help with providing basic care needs of our residents. Of course, once again, we don't do this unless we have very good reason to do so. It's really in your best interest to do some more exploration with your staff now before you need to operate a COVID unit. So you really want to think about what of your staff are working other places, and the predominating wisdom on that is trying to limit the number of facilities that staff members, even agency staff, go into. So having an agreement with an agency group, if you need to rely on agency, that your staff member will work exclusively with your facility, and that you may need to offer a specific number of shifts, et cetera, to make that worth their while. But you can do that, and that actually is a great process to get arranged now, to get some agreements in place if you would need to go into COVID unit mode. We've had a couple of COVID positive units, and we've had some success staffing them with agency staff with agencies with whom we've had these type of agreements. If you're now COVID positive, then it's not as critical that people aren't working at other facilities that might be COVID positive. But it's better for our residents to have consistent staffing. So we still encourage consistent staffing and a dedicated staff to that COVID unit. Next slide, please. And then I just want to put a mention on the morale piece. And I'm sure you all have also experienced this. Our world has gotten so much more intense. Our focus is 99% on infection control and prevention, and it should be at this point. We, of course, are still working to meet the needs of all of our residents. Our residents are self-isolating. That's very difficult. And if you have a COVID unit, there is a likelihood that you will have a percentage of the residents on that COVID unit may experience very life-threatening serious illness. And that is a difficult situation to support if you're not adequately prepared for it. So that's why it's important to educate your staff about the disease process. It's important to communicate as an IDT about what does the end of life look like with a COVID resident, and make sure that you have adequate benzodiazepines, opiates on board to be able to manage the air hunger that accompanies in a segment of these residents that accompanies the end of life process. So, and it can impact morale. So in addition to communicating extensively with your staff about your plans, processes all along the way, we also need to be providing some grief counseling to our staff members should they be a part of the end of life experience. I don't think we do that enough in our facilities, quite frankly. Our caregivers get close to the residents for whom they care, and we need to be able to help them go through a bereavement process around those residents. They get very close. That is one aspect in working with COVID that we do need to have some preparation around. But we communicate is really a cornerstone of good leadership during crisis. And so anticipating, what are people asking questions? What are they worried about? Watch their facial expressions when you talk about different topics. Have a process for routinely communicating with your residents, routinely communicating with your employees, and routinely communicating with the families. Now, there has been new guidance that recently came out that we are expected to inform the families and the residents when there is a change in our COVID status in our facility. And that can be if we have suspected or COVID positive cases for residents and employees all the way to COVID positive. So we've set up a process that we are sending out routine updates. I'd recommend that you be thinking about that as well. That helps keep everyone calm. Communication really helps people stay calm during a crisis. It's really important to also spend a lot of time recognizing the phenomenal work that our caregivers are doing every day. And as you all know, and many of you are caregivers, it's the work of God is what I say. And we have to constantly look for opportunities to acknowledge. There are so many wonderful hero banners, Heroes Work Here banners that are spreading out all across the nation. People just beam. We're always asking for those pictures, and we're putting them on websites and making sure we're celebrating our employees every day, because they are just wonderful and just so amazing. I also like Catch Me Doing It Right programs. We do the education. We give feedback at the time of education. And then having someone, department heads, they can have tokens, they can have candy bars, but something that they give to the staff when they're doing it correctly. because that also helps shape behavior in a positive way, and it really does boost the morale in the facility. I love also giving those tokens to residents to give to staff members when the residents feel like the staff members have done something correctly and that they feel safe in their care. It's another great way to really boost morale in the facility. So what we've talked about today is on, next slide please, sorry, we've talked through your plan, the importance of the plan, the importance of knowing your staff, knowing what you have now, going through your COVID unit process, and doing everything you can to be able to care for the residents while they're in your care. But what if you do find that you don't have enough staff and the National Guard isn't going to be able to send that staff? It might be that you'll need to transfer people out. So you may want to think about, are there any facilities in your community that are COVID positive facilities or COVID experienced facilities that you may want to transfer people to? It's important to have that. Are there any other alternative care sites that would provide that? Are there hotels that someone might be able to reside in that the county may have purchased? And then, of course, as we said, reaching out to your government agencies. It is critical to know when to ask for help. And if you see it coming, ask before that. If you've got a parent organization that you work with, make sure they're aware that you're struggling. It's important that they do that so they can help mobilize resources as well. Next slide, please. So we're hoping that none of us have the opportunity to have that COVID experienced facility, but the potential is there, especially in communities where there are large amounts of cases. Say like in King County in Washington, they were the epicenter initially. They still have it roaming around them. They're starting to plateau off and actually, reduce in cases, but there's still a lot of COVID in the community. So we're finding that the likelihood, now that we've restricted visitors, restricted vendors, that there still is a high likelihood that staff are bringing in the COVID into facilities. So you want to keep up all of your processes to try to prevent it. But if it gets in, then you can feel good that you've done everything you can for it not to have gotten into your facility. The staffing shortage can be the scariest part of that, one of the scariest part of that. But I hope we've given you some strategies and resources. Be sure to look at the CDC document that talks about what to do when there's a staffing shortage. And it very nicely lays out the concepts that I've talked about today. And you can walk through that. You can also walk through that with your public health department. And they will help you know when you can invoke contingency level, crisis level, and they can also put you in touch with resources. Plan, 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 anticipate, anticipate, anticipate. Do it as a team, and you're going to be successful in this venture. I think you're now ready for that battle, and I wish all of you the best of luck. And I think now we will open up for questions.
Okay, great. I actually want to invite Dr. Al Yazawa on the line at this point, because I just want to, if he has any comments about sort of he's head of the HIEMA response for long-term care services. And so I don't know if he wants to say anything, words of encouragement that, we're all here to support you.
Yeah, hi, Ida. Can you hear me?
Yes, yes.
Okay, I mean, I can just briefly speak to the fact that we are looking into designating COVID SNF. I mean, fortunately, our prevalence has been pretty low here in Hawaii. But that's something that we've been looking at for several weeks now. We've been meeting with a particular SNF weekly. We're looking at an alternate site as well. I've actually had some developments even today on that subject. So we hope to have something up and running soon. That's all I can really say about that.
And
So as every facility needs to prepare for their own, of course, we're gonna, Haima is trying to stand up outside resources in addition.
Yeah, the neighbor islands have been much better about this. A lot of the neighbor islands have already designated COVID SNFs. I think despite doing that, there's always a possibility that COVID can occur in any of the SNF facilities through community spread through our staff, right? That they're really the Trojan horses, like you said, Ida.
Okay, so let's just open up any questions, concerns that you just want to share. And also, I don't want to forget that if you are on the phone, I want to give you a reminder to let us know who you are, and for attendance purposes, and also enter your names for CME on the link. Okay, sounds like everybody's quiet. Oh,
Hello, this is Valerie Payton from St. Francis Hospice Bereavement Services, and I recognize there's going to be a tremendous need for bereavement support, not only in our facilities with our patients and their families, but with staff and also in the greater community. But you mentioned specifically bereavement support for staff when their patients are dying. And I just wondered, do you have any people or organizations that you can point to as being really exemplary in providing this kind of support? I'd like to try to put together some good ideas about this.
That's an excellent question. And many organizations do have palliative care programs that can be applied to the COVID-19 resident. There's several organizations that, well, the hospices, of course, are great partners in this regard. There's the LNAC, that is an organization just for end-of-life care that has excellent resources as well as chaplaincy organizations. I've put in place palliative care programs in a number of scenarios, and there are features of those programs that I think can be especially helpful. But I have to tell you, I think the hospice model is a great model for the, of course, end-of-life process, but also for managing the bereavement, the post-bereavement component. And I love partnering with our hospices and have the hospice come in and help run bereavement opportunities and groups for our caregivers. I think that is especially helpful. I don't know if that answers your question, but I think the hospice programs really have done a very nice job with that. And I love picking hospices to partner with that I know will help focus on bereavement. I do think we need to provide even more of that for our staff on a regular day, not just during the COVID pandemic, especially during this COVID pandemic, because it can be really difficult for the caregivers during the pandemic.
Thank you for the praise, and we could always do it better, and always looking for more ideas. Thank you.
Well, I will say, I do know of one that stands out in my mind, and it's, I don't know if you've heard of the Little Sisters of the Poor. It's, I'm trying to remember if they have a facility in Hawaii, but my mom actually is in one of the Little Sisters of the Poor. And I have to tell this story because I think it's so powerful. In her high school years, she used to volunteer in this one facility, and the facility eventually got replaced by a newer facility, but she had volunteered, and she always said that's where she wanted to live out her days. And she has a number of us siblings, and we were all really ready and willing to bring her into our homes. But she had witnessed how the Little Sisters of the Poor supported people through the dying process. And they were one of the first to establish what is sometimes referenced as a 24/7 vigil. And they stay with the resident and pray and sing. And it's just a very moving experience. So I think they also provide a nice model for that end of life experience.
Great.
Thank you.
Any other questions that you have? Okay.
Are you all sure? Because I know that it can be this is a concerning, and maybe it's more concerning as you potentially might face the scenario. But there's this is a real issue.
Mm-hmm. So I'm going to ask a question, just because I've heard it. So when somebody suddenly in your facility says, "Oh no, we have to test," and then all of a sudden the staff gets scared, and all of a sudden people call in sick for no apparent reason at all, how do you address that?
That's a really good question, and of course we have to follow the guidelines around how we manage when people call off. That is why I'm such an advocate of communicate beforehand. Coordinate this effort with your health department. See if you can schedule it so you have time to talk to your staff and allay their fears before the testing starts. Because I think that's when, that's the power of communication. We've seen really great success with having strong communication. So really planning ahead, having the discussion now, and then playing out different scenarios, finding out what people are scared about. We also, and there's some cases where staff members may not want to be tested. And so that is something that because of some cultural issues, quite frankly. So that's something that you need to work with your medical director on, your health department on, and tease through those issues. And it may be that that person ends up not being tested, but you may need to put in place some other mechanism to try to assure safety for the residents, like having that person self-isolate for a period of time, etc. So trying to plan ahead, have these conversations right now. When it happens, you are sort of stuck, right? When people have called in. So that's why you want to have that staffing plan. So when people might call in because they're nervous or fearful, you want to have a team to be able to communicate with them and help them work through those fears. We have a good process on PPE, and it is, we do everything we can to keep everyone safe, helping people feel comfortable about that. Also having those relationships with your agencies so you can call on them if you need to, if you get into a crunch. Having that cross training so you can pull people in to help provide care while you're getting through this moment of discussion. But your best plan truly is communicating first and getting and allaying people's fear and allowing it to be safe to talk about this and getting the fears out on the table.
Okay. Any other burning questions? Secret worries?
I think you guys are doing an awesome job in Hawaii, though. The cases really are. I track this twice a week. I specifically go out and look in Hawaii, and I'm just so impressed with the low number of cases. I don't want to jinx it. I think that and you've got some great processes and great people in your corner. So it's such a privilege to be able to work with facilities in Hawaii.
Thank you very much. So, okay, last call for questions. Anybody? Or comments?
Oh, what are we doing with resident masking?
Mm.
Great question. So any question around PPE has to start with what do you have available? That's always an important step. So what we're doing is we prioritize our PPE for the staff member, and especially the staff members who are working with suspected or positive COVID cases. So we will use our surgical masks and N95s, of course, for those scenarios. Frequently for our residents with masking, we're providing them with cloth masks and changing those, changing them regularly. We're asking that residents wear masks when they come out of their rooms. We're also asking that residents wear a facial covering when the staff member is in there to provide an aerosolizing procedure. If there's a way to also cover the resident so that there's less likelihood of transmission to the staff member. So those are the measures that we're taking around resident masking. Good question.
Great.
And the PPE questions probably are the most popular questions, I call them, because they can there's a lot of nuance. So we try to make it very clear, but sometimes it depends on availability.
Okay, great. Okay, so don't forget, guys, to register, and also you can log back in and download resources that we have, and this PowerPoint will be available as well on the same website. And yeah, you can also request CME and CE. And we're very excited about our next session on Monday, getting through the first case. So Dr. Sabine von Pressman, she's the Chief Medical Officer at Avalon Healthcare, and definitely has frontline experience on this. And actually, we have some colleagues on Maui also who've had some frontline experience on this, and we want to learn from them and get a heads up so we can go into this better prepared if, in fact, we do need it. So fortunately, nothing yet, but things could turn on a dime. So we all want to be super prepared. So looking forward to Monday. See you all then. Thank you.
Thank you.
Bye-bye.
Thank you.